Okay.
And that, we can still see the bones have the myeloma, but there's nothing pinching your spinal cord down there.
Okay,
So
that's what I was wondering too, because there's no.
at least
It cuts off, right? Or your
yeah,
spinal, yeah.
your spine, and once you get kind of in the lower part of the lumbar, it's just the nerve roots. But
Yeah.
but down there at least, I think the biggest thing we were worried about is just because
Pressure.
you're having pain, and it's also, but the legs are weaker than they normally are.
I do notice, and this was something that took. I think it's a circulation thing maybe down there because it's more of a pressure. Because I notice my feet are cold, way more than they normally are.
Yeah, and that can actually, believe it or not, sometimes that can be nerves too.
Really?
Because your nerves can kind of determine hot and cold, and so I think that it still could all just be the nerves getting pushed on. I know they're going to try and finish the MRI today for you, where they did
Yep.
So this one's
And that's going to be more on the back where the pain is.
Yeah, that's going to be more the middle back they're doing, from
Good.
Probably about here to there.
Okay, good.
And but I did talk with Dr. Lal, and I did talk to Dr. Alsawa as well, since he's not in the hospital this week, but he's in the clinic, so he's around. And
Gotcha.
And I told him that, hey, we could certainly try to do, or if you remember last time, Dr. Parzan did the radiation down here.
Yes, sir.
But I don't think it's unreasonable to try and do something up here.
Now we should probably just because of the severity of all that's going on, get a look at the MRI and then do a quick zap with the radiation.
I think that.
And this is something you bring in a gun or something, or I go down, or I would go into.
We would actually
your
bring
machine.
you down there just like we did
Okay.
before.
Now what
It's,
about lining up? Because I know they had these tattooed things on me to line me up for the specific. Now, so basically they could dial me in with these tattoos on this part.
What we would probably, just because it's been a little bit of time, we would probably just rescan this part of the spine, because they might not have scanned your whole spine last time when Dr. Parzan did it. So it would probably just be a pretty quick CAT scan. I don't know.
Okay.
I don't actually know if we would need to put new marks on you or anything.
I hope not, but whatever.
Especially if we're
They're
just
not
gonna.
big.
Especially if, like I said, my hope would be to maybe even just give you one big zap, so that we can try and get fast, quick relief. 'Cause
Yeah. Man.
I know one problem we have, obviously, is I know that when you get home, it's tougher for you to get back here, and so.
But I will tell you, as I've told maybe you and if I can get more pain relief, I know my legs will better, and I don't have my 7-year-old parents trying to help me get into a vehicle and snowing and all this stuff, and it's
right.
When I can't walk, it just totally. When I was walking before, we were kind of moving forward here and there, but.
And in that way, we won't be the reason that the next steps get slowed down or anything,
Sure.
And just like I mentioned, if we ever need to, if there's one area, I'm hoping that we would provide you some pain relief in that middle part of the back.
Now, what would be conducive for doing a radiation treatment if, in theory, they took the tumor out? Shouldn't there be in all prospects that there's nothing there? That's just, I don't know what's left over. We haven't seen, but
yeah.
Could there? What is your assumption we're going to see? Is this inflammation?
My concern is that even though they removed the tumor in this area that was pushing right on the back, but because you haven't had the whole body treatment from Dr. Alsawa, I'm worried that there might be something growing right near. It
could be an infiltration area from the myeloma.
It could be,
or a spot it's going towards, making it progressively more of a problem.
It could be making it more narrow, and usually the area of the pain correlates with where the nerve's getting pinched. Because if it was your spine's way up here, if it was in the back of the neck getting pinched, I think you would feel the pain more up here.
Oh yeah, nothing.
And you would have weakness in the arms too.
Yeah,
This, you said your pain is
right there.
Is it between the shoulder blades?
No,
or is it
it's
a little bit
right
lower?
there, right there.
Okay.
Almost right straight behind my belly button.
Okay.
From there down, everything has a little bit of something weird, numbing, tingling pain, but in just the last month, 90% of the pain is right in that surgical area.
Okay, and
so
and I think, like I said, I think that we could try and bring you down for the. I think it would probably be 2 trips down to the department. One just to I would want to just rescan that area, and then the second trip would be just for the actual treatment, and like I said, it might be something where we can try and do it while you're in here, and then it's a quick treatment that hopefully is going to work pretty quickly.
That would be great.
So and that way, like I said, I don't want to have Dr. Alsawa's part keep getting delayed. I'm hoping that we can
Yeah, I'm ready to go. So.
help you out a little bit, But you said you're getting a MRI at 1:30 today?
Yes, sir.
Okay.
I made it through the first one, which I was a little bit quite skeptical because I've been having panic attacks. And I'll tell you, a lot of
Did that
these.
go a little bit better yesterday?
Oh,
for you?
yeah.
Good.
Part of it is these newer, for whatever reason, the Dilaudid is awesome. I don't have mental anguish. Like all these other hydrocodone, Percocets, all these, I was just paranoid, fearful, panic, and even my morphine. Finally, like just in the last three days after being in here, kind of getting off all that, just doing the Dilaudid, and my mind's clear. I think it's just pain now, which is great. So if we could minimize that, I'll get on my exercise regimen. I'll get back moving, man.
Yeah, that's kind of what our hope is, and I always tell people that if we do the zap, our hope, because myeloma is usually real sensitive to the radiation. Our hope is that your pain gets better within a couple days, but sometimes it takes a few days. So I always tell people, don't get discouraged if it doesn't happen.
I'm usually
overnight
pretty,
for
I feel pretty confident.
you.
Now, is there a difference between inflammation and what I'm dealing with, or is it mixed in with the myeloma?
I think it's kind of
myeloma causes inflammation.
I think that's the I think that the myeloma itself, like what happens is it grows, and when it grows, it pushes on things, and then the spine, when it pushes on the spine gets inflamed. So that so because otherwise, unless you had some, like for the most part, it'd be really unusual for your spinal cord to just get inflamed for no reason. Gosh, I guess they could see it in like MS or something like that.
Well, someone said my dad or some kind of post scar tissue nerve regeneration where, I don't know, my body just shuts down the pain, and then months later, all of a sudden now I'm feeling the surgical pain.
And that there's always that's part of the reason we'll get the MRI, but usually what happens is when people have an area removed from the spine that's a tumor of almost any kind, usually it's not a bad idea to do a little radiation shortly after, just because if they often don't cut every little cell they can find out. They usually just kind of
and let radiation do the rest, or chemo.
Yeah, basically, they just want to make sure they decompress the spine. Because obviously you can see what happens when the spine's getting pushed on is all of a sudden your bladder's not functioning right.
I did have a secondary thought on that, and I was would it really seem that, or couldn't it possibly seem that all along this walking and peeing thing was from my L5 and not the surgical area?
It's I think that it's tough to say, because we do know that, like, especially the urinating problem, sometimes that can be in that lumbar lower area, because you got a whole separate set of nerves down there. But one thing we know about the one thing we know about the spine is that basically the spine kind of starts here, and it travels all the way down, so that we can usually, based on the symptoms, like you said, you get numbness kind of below the belly button. That usually tells us kind of where the spine is not functioning perfectly normally, because if it was, like I said, if you were having trouble higher in the spine, you might have the numbness starting up here, or lower.
I know, it's tough. I mean, there's so many things going on there.
It's tough to say exactly.
I guess just after the fact, I'm almost thinking that, we should have just done radiation, minimize this one, and focus more on the alpha. It's after the fact, but
and it's tough.
It's
because,
just this surgery has now become
the surgeons. Yeah, that's
been
become
the
a
most
problem
problematic.
area. But we'll have to kind of see on the scan, because the tricky part about the myeloma is sometimes it's, if we don't get you on something that starts just shrinking it through the whole body, then what can happen is eventually, just new spots will cause grief. I had a guy I had to treat a couple, not even a month ago, who you know, he's having this arm pain, and you know, and they had a big old spot in the arm, you know, and that's kind of how they found it. So everyone's a little different though, you know, and but but you know what we can do then is, let's see what time is it's about so we can bring you down for the radiation planning scan tomorrow, or if you like, I could try to get you down soon, but
we could go after the MRI maybe, but I'm really tired after they're going to give me.
Yeah, you know,
I couldn't make it through the other ones I was getting with the medicines, all those drugs. I was in a panic. I was just mental torment.
Yeah,
and now I feel mentally great, but
well, good. You know, I could see maybe
they dope me up pretty much.
You know, maybe we could, you know, the CAT scan won't take real long. Maybe we could actually do that today before the MRI.
Yeah, let's do it.
Then,
man.
you know, I can just ask my staff if they could bring you down in the next, you know, maybe half hour or something.
Oh, you mean before? I wouldn't recommend that, only because of the sugar. Like I panic. Well, I shouldn't panic as much because my mind's better, but being in that tube, it wasn't like a joyride, but I was so kind of out of it that the 45 minutes seemed like 10 minutes, and I was cool with that.
Okay.
But
do you remember the tube from the CAT scan, like for like it's kind of like
that's not bad.
The donut?
That's not bad.
Okay.
Yeah, I've done that enough. But they give me this Alduit thing, this injection, and then I also do my pain management, and that just kind of gets me to a mode where, because I want to get this done and not move at all.
So you need a little time, you think, before
and with the sugar,
MRI.
And what causes me to panic is when I feel that pain and I can't move, and then I'm in the tube, and then they're like, "Sir, you're moving," and then it's all done.
You can't make the adjustment. Well, you
so
know what, then
I would definitely wait till after that.
Let's get you through the MRI. You know, I'm not sure if we could bring you down right afterwards today, but
if you can, fine. If
not, we'll try and maybe just do it early tomorrow, okay? And we could even maybe do the radiation treatment the same day potentially. Like I said, I want to get it done so that you can try and start improving. I don't know if you know. I know that you're feeling a little bit better than when you came in, obviously, but
oh yeah, and I think partially also the steroids, I could tell, I think is a good buffer, which I know there's, you know, with that being a little bit overkill after so much time, but I don't know, like I said, you guys are the ones that have to decide. I wouldn't say it's my cure-all, and there's other factors with the weather. I said I've come in many times, pretty much all my appointments being in ER, it was cold and wet.
Yeah.
Snowing or and I'm from Florida, my blood, I don't know if that's part of it, but I could tell you almost even at home or here, MRI or emergency visits, my pain goes from nothing to, even just in a couple hours, we'll get a cold front coming in, and
that makes it all worse, huh? Okay. Well, you know,
but that's dissipating. You know, we're going to get warmer weather.
Yeah.
I do feel I have a pain regimen that's going to work.
Yeah, definitely.
Maybe keep the steroids a little bit, you know, on board, and I think
they will. I don't think, you know, my hope is that if we can zap a problem area for you, that they can maybe taper you a little bit off the steroids. But I mean, right now there's no reason to mess with them if they're helping. And you know, and actually, I'm sure Dr. Alsawa probably told you that part of the normal treatment is to actually do steroids with the immune type therapy they use. So, you know, but you know what? Then let's just work on getting you through that MRI today.
Yeah.
And we'll circle back with you tomorrow morning. Okay.
Can I do two quick questions?
Yeah,
one,
of course.
Any reason that a prozone injection in my back, or what do you call it?
Like a cortisone injection?
Yeah, wouldn't do anything. And I know I've had
know,
many doctors like, no.
I think that, unfortunately, I think that if they did a lot of times they'll do that like in the muscle areas and stuff, and I don't know that would really
maybe
help.
After the MRI they would maybe it's a Band-Aid, but I've heard so many people rave like, oh man, I had this massive pain.
A lot of times that's really good for like an arthritis type pain, you know,
and you don't think this has nothing to do with that?
I think that if we know that the bones right now have that abnormal cells in them, and they're getting pushed.
The protein, M proteins, right?
Yeah, they're getting the bones are getting pushed a little bit, you know. So I do think that you know, when Dr. Alsawa can start you on the whole body therapy, it's likely to help everywhere, you know. But let's get that MRI of the spine, because that might, like I said, that might help us kind of hone in a little bit on where the biggest problem is.
Okay. And now with the chemo, like, you know, is it? I don't know. Like, I think I get a lot of impressions that I'm not tolerable of pain, but I mean, I'm a very athletic guy. I'm very aggressive, and just, I mean, I've been 48, never been to the hospital. Believe me, I've hurt myself pretty bad, and I'm like, not a big deal.
Yeah.
Walk it off. So I don't know if people are just thinking I'm not, but in the chemo aspect of this, I mean, where would I lie to leverage? I just don't want it to become an ER because I'm having, and I've heard some stories with chemo and how bad off am I with the chemo treatment, how invasive, how intense levels of pain. I guess that's something to talk with Alsawi about.
Yeah, I think Dr. Alsawa is probably a little bit better just as far as kind of how it's all tolerated. Generally, I mean, granted, I told you that we do the radiation kind of just focused areas, but we do see people going through the treatments. Generally, though, people do fairly well with it. It's not quite as rough as some of the other types where people are, throwing up and losing hair and all that. I think it's generally a bit better tolerated.
What was concerning, or not concerning, but questionable to me is, it seems like this regimen that Alsawa
Yeah, Alsawa
has is very generic. Like he's like, no, we use this for all cancer. So is it just basically that cancer is cancer and we start with this and see what happens?
I think that I do think that for myeloma we use slightly different combinations than for other types of cancer. I do think that what he's, and I'd have to ask him exactly what drug he wants to start you with, but most of the time there is kind of like we call like a first line therapy for myeloma, and usually that involves usually that involves like the steroids I said are one part of it, and then the other part of it's usually like a biologic type thing. It's not just like a chemo, it's like just something that's more targeted. But I definitely, and I think Dr. Lal, when he has he come to see you yet today?
I think so. I'm trying to remember Lal.
That's okay.
Faces.
He might come with Candy sometimes, the nurse practitioner, or David.
Okay, yeah, Candy, I think.
They're, if you want to ask them a little bit about like, hey, what's Dr. Alsawa's first regimen? What are the plans for it? I think, like I said, most of the time that's not something they give you in the hospital. But you could ask them.
I mean, I don't want to get too much into that. Let's just get it moving forward. But I also don't want to be like, kind of like, hey, let's look at the information, apply a proper treatment, because it's.
Well,
I know.
I can tell you one thing that probably will help you out is actually they usually will have a what's called a chemo teach, regardless if it's chemo or immune therapy or whatever. The nurse practitioners like Candy or David will have a separate session for you where they actually sit down, go over the like all the side effects you could expect, kind of how guys will tolerate it. So I do think that'll happen before long here.
And is there a way to minimize the shots? I'm not a good shot person, but is there any injection shots or?
I'm not sure.
I hope not.
I would have to check.
I'd almost rather just keep this IV in me, really.
Well, if I can tell you that sometimes if people are having a lot of trouble with like the infusions, they'll do a port in you, but
Oh yeah, I don't really want that either. But we'll
my
see.
guess is for this type of treatment, I don't think you'd need it.
Okay,
but,
cool.
But listen, I do want to wish you luck for the MRI today.
Thank you.
And like I said, I want to check in with you tomorrow morning, okay? And
I'll be here.
If this is looking good, we'll just we'll get everything moving, okay?
Awesome.
All right.
Hey, enjoy your day, and I'll see you tomorrow or tonight, maybe.
We'll see you tomorrow morning. All right.
Cool. Send the check, dude. I'm dying, cancer, freaking bump up the disability money. Gotta get the cash flow, dude. Gotta play this out to the ultimate max. Okay, I'm done.